of jobs. So it's a big list of 800 jobs, and they classify these jobs to different risk factor, and to be infected is one of this risk factor. And here you see the top three. Number 3, ladies and gentlemen, is working in a coal mine. And on the next slide, there you can see the top 2. Number 2, where is my next slide? Yeah, here it is. Number 2, ladies and gentlemen, is being a dentist. And number 2 is being a prophylactic dental hygienist, dental assistant, however you call that, during prophylaxis. Of course, this is a training slide, a training picture. Of course, this is not a good suction technique. Of course, this is a bad equipment there. There is no mask, there is no mouth-nose protection. She did not wear gloves, etc., etc., etc. So, yes, this is a training image. Nevertheless, this is the result of this American study where they compare 800 different jobs. Number 3, working in a coal mine. Number 2, being a dentist. And number 1 is a dental assistant. Well, there are other studies too, which are maybe a little more scientific, but it's clear that dental personnel, you are constantly exposed to these organisms, and you will see that there are a lot of papers that prove that there is a higher risk suffering on hepatitis. C is the highest risk because there is a vaccination available against B. Well, HIV, I would say, okay, the amount of blood would be too high to be infected, so the risk is relative low, but there is a high risk suffering on tuberculosis. And still today in Germany, each year 100 people are dying in Germany because of tuberculosis, and 5,000 new infections each year in Germany. Well, herpes, okay, it's a problem, but it's not serious. But now we are talking about the SARS-CoV-2, the new coronavirus. And there was a very early paper from Peng, a Chinese study from February, so on a very early time, where they really prove and demonstrate that working in dentistry is a very high risk, but you can prevent. So it is a high risk, but therefore there is a high, let's say, hygiene level in dentistry. We use gloves, we use masks since years. So therefore the infection risk is on average. There is a comment in the questions that some of you do not see the slides. So in these cases, I just recommend to log off and log on once again to check out your connection. So that's my tip whenever there is a problem with the internet connection and with the presentation. So let's go to our agenda. My agenda is that I want to discuss with you the risk being infected via a dental aerosol. And it's really a discussion because I will show you the studies, I will show you the papers that are published, but you will see that there is no result. Yes, it is a risk. So we have to do our own risk assessment. And I want to give you not an answer. You have to check it out by yourself. What is my risk assessment? So there is no study. That's my first statement. There is no study that proves that you can be infected on a dental aerosol by SARS-CoV-2. That's not available yet. But I think it's very realistic, the threat. So therefore, I will offer you some measures. I call it the principle of non-contamination to handle that risk. Well, and on the third issue is, well, nothing is 100% safe. So we have to, let's say, discuss the plan B. What is our plan B if nothing is 100% safe? And then we will end by our discussion. Ladies and gentlemen, before we go to our issue, dental aerosols, and discuss the threat, I want to ask you, because it is not possible to activate all your micros, but now there are more than 200 attendees, so I want to ask you a question. Because I want to learn a little bit about your situation in your country. And my question is, are your practices currently operational? Because we saw that there is a second wave coming, and the situation is different from each week to another. So my question to you is, are your practices currently operational? So just click on closed emergencies only or yes. So I now will publish the result, and you can see the situation in the different countries. So my question is, what is your regulation in your countries? Are your practices currently operational? Are they closed because of some legal things? Because of some threats, patients are not coming, emergencies only, or you can start working. Okay, approximately 70% votes now, and then I will close it now. Yeah, now let's publish it. The result is quite surprising, I think. And this is the result. Only 9% are closed. Let me tell you that some weeks, let's say April, this was approximately 50%. So 9% are closed, 32 emergencies only, and approximately 60% are opened. So thanks a lot for your reply. And really, this is quite surprising for me because the situation changes from day to day. Okay, let's come now and let's talk about dental aerosols. This is just an introduction so that you know we speak from the right thing. Sometimes I say coronavirus. Of course, when I say coronavirus, I mean the SARS-CoV-2. Well, I know the disease is called COVID-19, and we know that not everybody suffers of this disease. There are a lot of people without any symptoms, but they can infect others. Well, still the main route of transmission, that's what the Robert Koch Institute say, is via droplets. But there is today a big discussion if aerosols plays a much higher role than droplets. And this comes also together with some studies, because we know that the spikes, the receptors, these corona spikes, they attach to a protein which is called ACE2. And this protein, we find out that this protein is in a very high concentrate on some cells, endothelial cells inside the nose. So we think that this is another pathway to enter the lung via the nose, via inhalation. And well, we know that especially aerosols will be inhaled via the nose. So therefore, it's very important that you wear your mouth-nose mask as a mouth-nose mask, and not only as a mouth mask. So that's very, very important. So really protect your nose. This could be a much, let's say, better pathway, a much more important pathway than just these droplets. Well, and the contamination, the infection via surfaces, via indirect contact, this plays, well, that's the statement of the Robert Koch Institute, a minor role in the pathway. So therefore, people are afraid going to supermarket, to shopping, and they disinfect everything, and they wear gloves, etc., etc. This looks like that it's only a minor pathway. But aerosols plays, especially over the last weeks, a major role in this discussion. So therefore, we will talk now about these aerosols. When we look into dentistry, then we saw that we generate a lot of spray mist because we have to cool instruments, especially these high-speed rotary instruments, like the drills, ultrasonic scalers. These instruments, they generate heat. This heat will denaturate our pulp, will destroy our nerves, so therefore we have to cool it. We cool it with water and not with air. We cool it with water, and this water sprays around, generates this spray mist. That's what we call spray mist. Well, on the other side, we use our 3-in-1 piston, the air and water syringe, and also this will also generate a high load of aerosols. In Germany, for instance, it's recommended to use the 3-in-1 piston either for rinsing with water or for drying with air, but never together. So, and this will dramatically reduce the risk of generating this aerosol. So that's my first tip. The 3-in-1 piston, it's not anymore a 3-in-1 piston, it's a 2-in-1 piston using either water or air, but never together, because this will generate these aerosols. So, but the problem, all the other aerosol generating procedures that if you look in some studies, they always talk about the AGPs, the aerosol generating procedures. We cannot avoid it because we have to use these instruments, and going back to, let's say, manual instruments, that's not a solution. That would be, let's say, like going hundreds of years back to dentistry, where we do everything by hand. So let's go a little bit more in detail and let's look inside that spray mist. Well, this spray mist contains solid particles like this powders from the prophylactic powder jet handpieces. So that's solid particles. But that's not an issue concerning the coronavirus, because the gravity forced them just to contaminate 10, 20 centimeters. So that's not the problem. And then we generate the bigger droplets. We call it splatter. Well, and they contain saliva, they contain solid particles like amalgam, like dentine, of course, enamel, gold particles, powders, etc., but also biofilms. So they are heavily contaminated. We will look into some studies later on. But the good news is you can protect yourself very easily by wearing a mask or wearing a shield, a face shield, or goggles, gloves. So we are protected against that splatter. So now we have to discuss about aerosols, because per definition an aerosol is smaller than 50 microns. And we call a droplet or a splatter an aerosol when the gravity is in the gravity and the flow of the air is in balance. So there is no natural gravity, and then we call it aerosols or airborne particles. That would be another name. So 50 microns and smaller. And they will not contain solid particles because then the gravity would be too high. So they contain only liquid components and bacteria and viruses, of course. So I want to show you a video from yesterday. Yesterday, we go to an institute because we want to know the production, and we want to understand the production of these aerosols on a drill. And this was a turbine. And you will see the video. I started now, and I'm not sure that the transmission is fast enough that you can see this fluently. But I think I stop right now. So, and this is the still image. And I think you understand and you see that there is a dramatic production of different sizes, smaller particles, larger particles, if you switch on your turbine. And now we want to understand what are the dimensions of these particles, because when the dimension is smaller than 10 microns, we'll see this of one of our next slide. When the dimension is smaller than 10 microns, then there is a risk that these particles will enter the lung, the alveoli, and that's the problem. And so whenever the particle is smaller than 10 microns, these are the, let's say, the important aerosols. And what you see there is an automatic calculation of the amount of this spray mist. There are some huge droplets available, yes, but the main size of the particles you produce with a turbine are 10 microns and smaller. That's what you see on the right graph. With this measurement, we can measure particles from 10 microns and larger. So therefore, this histogram stops at 10 microns. But believe me, it will be 10 microns and smaller. These are the typical dimensions you generate with a turbine. And this is the highest risk, because especially these small particles, those particles will enter the lung, the alveoli. Okay, ladies and gentlemen, let's go back to our saliva, because this is just physics. This is just a physical effect. And now we check on the second parameter. The physics is one. Now we check the let's say the biological component, the microbiology. We know, ladies and gentlemen, that saliva is heavily contaminated with bacteria. 600 different types, 100 million per milliliter saliva. But we know also that viruses are part of this saliva. 2,000 viruses of hepatitis C and 160,000 viral particles per milliliter when we talk about SARS-CoV-2. It seems to be very high, but ladies and gentlemen, this 160,000, these are RNA copies. You know the methods to test the viruses, these PCR methods. If you count the number of viruses, the PCR technique is the easiest way, but then you just count the copy of an RNA virus. So you count just the RNA. And this is not a proof that this RNA particle is able to infect people. So therefore, all we know is that there are a lot of copies inside the aerosols, but there is no proof that you could be infected with these aerosols. And therefore, we have to do a risk assessment now. And this is one of, I think, the best studies made by Bennett, published in the British Dental Journal in the year 2000. And the aim of his study was to prove or to do a risk assessment. Could you be infected by tuberculosis during inhalation, during a 15 minutes treatment? And that was the aim, the target of the study of Bennett et al. So is it possible that you are infected with tuberculosis if you perform a 15 minutes treatment without any protection, just by inhalation of the air, the aerosol? And what you see on that slide, and I will activate now my drawing tools so I can show you it a little bit more in detail. This is a timeline in one morning in a dental clinic. So it's an in vivo study. It's not in a lab, which I think it's very important. So it's an in vivo study in a dental clinic. This is just one example. He tests a lot of samples. This is just one example. The clinic starts at 8, treating the first patient, treating the second patient, third, 4th, 5th, 6th. So 6 patients in this morning. What you see there on the x-axis is the time. What you can see on the y-axis is the number of bacteria they can count in 2-meter distance. So the number of bacteria, colony-forming units in 2-meter distance. what you see is it starts with a baseline there. So air is not sterile, and that's these 800 counts per cubic meter air. So, and then we just follow the red line. Then the first patient came in, nothing happens. But the second patient will generate this peak. And this peak will result in an increase of the bacterial load to a factor of 8. And the duration is 30 minutes. So you treat a minute and then it will not go back to the base level. It needs 30 minutes until the air is exchanged, or maybe this aerosol settled down. It needs 30 minutes. And because of this study, in Germany, we recommend do not enter the room for 30 minutes if you treat a risk patient. So that's the recommendation in Germany. Do not enter the room if you treat a risk patient for 30 minutes, because that's the time this aerosol needs by gravity to go down to the ground. Well, in many countries, there is a recommendation to open the window, to dilute the aerosol. Yes, of course. That's also a very good tip. Do open the window, dilute the air, exchange the air if you treat a risk patient. So that's because of this effect. 2 meter distance, bacteria from the patient's mouth. And then they treat the next patient. Nothing happened. Patient number 4, another peak. Patient number 5, another peak. Patient number 6, no peak. So, and then Mr. Bennett asked, well, what are the risks? Where are the risks? And, well, the risks are ultrasound, prophylactic treatment, and turbine. But in 10%, and that's another result of his study, there is always 10% risk for each dental treatment. Maybe because of the 3-in-1 piston, we do not know. And that's one of his results. We can never avoid the generating of aerosol. So that's the consequence of this studies from 2000. Oh, by the way, there is a literature list in your handout with all the literatures, and you can click on them. And if they are well published under the common license, you can download the PDF. If not, well, then you have to pay for this literature. But there is a literature list at the end of my handout. And once again, you can download my handout. On the right side, there's also a chat tool if you want to ask something, want to interrupt me. So please use the chat tool to ask some questions. So what is my consequence and what is my discussion background? Well, it's proven that it is possible being infected with tuberculosis and hepatitis C during a dental treatment. Bennett shows that you inhalate 0.12 microliter of saliva from a patient's mouth. And when we do now just a simple calculation, 158,000 copies of the RNA of SARS-CoV-2 per milliliter saliva, inhalation of 0.1 microliters, this will result in 2 to 20 coronaviruses per treatment. If this is enough, nobody knows. I read in a latest study that they estimate that the bacterial load should be some tens to some thousands coronaviruses to be infected. So even that, it's not proven yet. So we do not know that if this is enough, but well, my risk assessment would be go in this direction to say, okay, I think it's proven. And now we can talk about the measures. So, ladies and gentlemen, another slide that maybe gives you some better ideas. When we talk about the risk being infected by aerosols, the highest risk is by aerosols, by particles within the range of 0.5 to 10 microns, because they reach the alveoli. It is proven that even the small particles can be associated with SARS-CoV-2, can be contaminated with SARS-CoV-2. That's proven. And it's also proven that they are stable inside aerosols. They maintain infectivity. That's also proven. And these are our own studies from yesterday. It's also proven that your turbine, for example, generates a very high number of aerosol particles smaller than 2 microns. So I think my estimation is very realistic that there is a risk being infected via these aerosols. What is the consequence of the Robert Koch Institute in Germany? In March, they published on their website, there is no evidence available yet. And then they changed their opinion in the middle of April, and now they classify dental procedures as a high-risk setting, and therefore you have to perform some measures to handle that. Well, let's look to the United States. The CDC published, and I checked it out latest on 17th of June, that they still publish that there are no data available, that there is, no evidence to say yes or no, but they recommend using a high evacuation suction. They recommend using rubber dam. They recommend to work with four-handed technique. That's what they recommend. Well, and they recommend finally to minimize this splatter and aerosols. That's what they publish on their website. Maybe there are regulations in your country. And this led me to my second question. What do you think are your local regulations in dentistry to protect yourself? Are these sufficient? Yes, no, or don't know? In Germany, I think our local regulations are now, so beginning of July, sufficient, but they wasn't in March and in April. So what do you think? Are your local regulations working safe in dentistry sufficient? Yes or no? Or maybe don't know. So 60% vote. Give you another 10 seconds. Okay, thank you very much. I will close it and I will publish it once again. These are the results. Oh, that's surprising. 50%, 48% say yes, they are sufficient. Okay, thank you very much. 25 say no, and 27 don't know. Thanks a lot. That's quite surprising. Okay, let me go to my presentation and let me continue. We are now talking about our measures. So if we came to the result, we have to protect and we have to do something and there is a risk. Let's now discuss the principle of non-contamination because, if you don't generate these aerosols, and we know that the generation spot is the turbine, the drill, or the ultrasound scaler, or the 3-in-1 piston. So that's the spot where this aerosol are produced. So then we have to check what happened, how can we prevent? And the easiest way to prevent these aerosols is using a high volume suction system. This is a study from Germany, and Mr. Reitemeyer checks out the area with or without this high volume suction system, and it checks out the contamination area. And what you see is on the graph on the right side, if you do not use a high volume suction system, then you could contaminate approximately, let's say, 1.5 meter in distance. If you use a high volume suction system, then you just contaminate, let's say, 20 centimeter in diameter. This is because of these heavy particles. Yeah, especially the powders, they've got such a high speed, such a high energy. Well, you cannot avoid that, but they will not part of these aerosols. Yeah, so from the infection point of view, it's not a problem. I want to show you a video, a graph that explains why 300 liter per minute flow rate is the European standard for a high volume suction system. Because a high volume suction system is just a word. And many dentists are testing a suction system with the thumb. You know what I mean is, you can check this out now in the webcam. Yeah, they use the thumb and the suction system, and if it stays on the thumb, then they say, okay, that's sufficient, that's great. Sorry, what you check is the vacuum. You do not check the volume. To remove an aerosol, you need volume, flow rate, liter per minute, and not vacuum. Yeah, so therefore, the flow rate is the important parameter. And now we can discuss what is the best flow rate. Is it 100, 200, 300, or 800 liter per minute? That is on that graph. So what you see on the x-axis is the flow rate. What you see on the y-axis is the efficiency removing aerosol. And the first curve is an optimum line. So I think that's clear. When you increase the flow rate, when you increase the flow rate, then this will yield 100% efficiency at the end. But you cannot use 800 liter per minute. The noise would be too high, and you will remove the cooling water. If you remove the cooling water without cooling, then you increase the temperature, and this is the negative effect. So by increasing the flow rate, you have to pay a negative effect, and that's this line. So this is the increasing heat on the tooth. And now you have to make a calculation. Positive effect, negative effect, and this is this optimum line. And this optimum line results in, let's say, an optimum field, and this is between 250 and 300 liter per minute, which is the optimum of a high volume suction system. If you use just a Venturi system without a suction machine, this would be around 100 liter per minute. So that means your aerosols efficiency is only 50% approximately. So only 50%. By using a high volume suction system with 300 liter per minute, it would be more than 90%. So that's the difference. 50% more than 90%. And this is because of that figure. Okay, this study is not made by Dur. All these studies about aerosol reduction and the physics behind that are from the 70s. As I said, these spray mist suction systems are developed from different manufacturers in the 60s. Yeah? So we talk about technique that is 50 years old. And this high volume suction system is really a European standard, I know, and not quite common in other countries. But today, when we talk about aerosol reduction, this is an issue. Well, some other statements. This is a very important study there. Criteria of airflow and negative pressure to volume suction systems, and the statement there. So I want to show you a video there, the result. And I want to, what you can see on the video, maybe if the internet is a little bit slow. What you see on the video is an aerosol cloud without a suction system. And within that video, we switch on the suction system in second number 20. And I will restart the video once again. It's on YouTube, on durdental.com on YouTube. And there you can see the effect when you switch on the suction system. So once again, I restart that. So in the beginning, you will see the aerosol cloud. And after 20 seconds, we switch on the suction system, and this aerosol cloud is, let's say, reduced to 90%. There are still some droplets coming out of the mouth, but these dimensions are too large, I explained that already, to enter the lung. Yeah, so you can really prove that very nicely. So another study that proves you need that 300 liter per minute, and therefore you need suction systems, and you need powerful suction systems. Well, Durdental offers these kind of suction systems, but this is just one way. Because the weakest part in that suction line defines the volume. That means you can work with a perfect suction system, with a very strong suction system, like from Durdental. If you use a small cannula, then you ruin your flow rate. And therefore, we recommend to use a huge suction cannula with a diameter of minimum 8 to 10 to 12 millimeter. A suction cannula is a retractor tool, a holding tool. Yeah, that's, you can see on the right figure there. This is the assistant. She works on with a four-handed technique, and she offers the treatment area by placing the patient's head in the right position, by placing the patient's body in the right position. And then this is a perfect suction technique. And this, together with a high volume, will result in more than 95% aerosol reduction. So it's always a combination between technique plus handling. It's always a combination to reduce the aerosol. Ladies and gentlemen, is this a solution? On the next slide, you see a so-called extraoral vacuum system. It's not made by Dur, and it's not offered by Dur, because I think this is not a solution to give you an answer right now. And the only argument, so these are two pictures from the brochure of the manufacturers. You see that you have to place a funnel over the patient's head. The efficiency depends on the distance. So if you keep 20 centimeter distance, then the efficiency is very small. So to have efficiency, you need a small distance, like you see on the right figure, on the right picture. But this will yield in that view. So this is perfect ergonomic on the next slide. You see four-handed dentistry. You see the assistant with a perfect holding technique. You see the dentist with a perfect view, 40 centimeter distance, ergonomic procedure, ergonomic treatment, no problems with the back and with the shoulder. And then you place the funnel, and then it looks like this. You ruin your technique by these kind of funnels. And then you have to bend your back once again to the left and to the right to have a view. And that's my opinion, absolutely not possible. So therefore, I think that's not a solution. I think the principle of non-contamination, to solve the problem where you generate the problem inside the mouth, that's, I think, is the best strategy. But do not use a saliva ejector alone, because that's my next video. use a saliva extractor. A saliva extractor will remove the saliva that's, in the bag, but will not remove the aerosols. So that's maybe what you can see on the video there. If you use only a saliva extractor, this will not prevent the aerosols. You can use it additionally to a high volume system, but not as a lone strategic possibility. So always use large cannulas and a strong suction system. Well, of course, there are some cannulas available on the market. There is a cannula available from Dentsply Sirona with a mirror in between. Well, of course, this is a nice idea. We developed a so-called prophylaxis cannula. Maybe you can check this in the webcam. This prophylactic cannula gets a shield that you can turn around by 360 degrees. And the big advantage are the prophylactic treatments, especially when you work with this powder jet handpieces. The energy of this powder is so high so that they will really be deflected on this shield. This prophylactic cannula was developed by a dental hygienist, and she's got a nice idea and say, well, there is an idea. I need a partner to bring it on the market. So it came out from the practice. And ladies and gentlemen, whenever you have got some ideas like this, there is a website, Duo-Innovation. Please give us a call. There are still many ideas about suction, preventing aerosols coming from the practice. So give us these ideas, and it will help. The result is that you can double the intake of aerosols by this prophylaxis cannula. So a strong suction system at the back, plus the right cannula that will reduce the aerosols. So that's what I mean on the next slide with huge suction cannulas, 8 millimeter, 10 millimeter dimensions. And this is not just a hose. Yeah? This is an ergonomic tool to hold and to retract the gum, to retract the gingiva, to hold the tongue. It's a tool, and it's not only a suction tool. So, ladies and gentlemen, let me check my time. It's 10 minutes once again. That brings me to another problem. If you remove the aerosol with a good suction technique, the problem is not solved. It stays inside your suction line. And especially when you use a Venturi system, then you generate your vacuum inside your dental unit. Do you ever think, what about with the exhaust air? The exhaust air is blown inside the room without any filter. So you remove the aerosol on the one side, on the right side, and then you blow the exhaust air, the aerosol, once again back into your room. That's a problem. Well, from dental's point of view, you collect everything on the suction system, on the suction machine, but there is also an exhaust line. And we recommend, and it's not only a recommendation, if you look inside the instruction for use manual, that we say you have to install a bacterial filter to reduce bacteria and viruses when you guide this exhaust air to public areas and not to the roof. So therefore, we recommend to check your exhaust air, because inside the exhaust air, there will be these aerosols. So that's my recommendation. Check out the exhaust air, install filters. Whenever there is an exhaust air, there is also exhaust air coming from steam sterilizers There is also air that you use for compressors. So whenever you use or there is some issue with air, check out the filters, and there are filters available to filter out the virus and the bacteria. But you have to check it. So in case of suction line, all this bacteria and viruses, most of them stay in the suction line. And it looks like that if you do not prevent. Finally, you block and you ruin your suction line by not cleaning and disinfecting and not by decontamination in it. Well, these are special waves. The price is high, so therefore don't ruin your suction systems by using aggressive cleaning agents or aggressive disinfections like H2O2 or whatever. There are special products on the market. We developed that more than 50 years ago. Aerosol Plus is the disinfectant. You use it once a day, over the night. It reacts over the night. So in the morning, you rinse it with water, you flush it with water, and then it's virucidal. That kills also the coronavirus. That's the left product. And the white ones is an acid, especially when you use these prophylactic powders. You need an acid to dilute these salts. This is chemistry. Yeah? You always need an acid to remove these salts. So Aerosol is an alkali, like all disinfectants. Then you need an acid additionally once a week, for example, to get rid of the powders and the calculus that stays inside your suction line. So that brings me to the end. Nothing is 100% safe. So, ladies and gentlemen, of course you have to wear protective equipment. That's clear. And of course you have to wear the right masks. And I know that there is a big discussion about masks, wearing shields, etc. But this would be too much to discuss this in this lecture, in this session. But finally, you cannot prevent everything. You can remove 90%, but not 100%. And now we can discuss about additional methods. Disinfecting surfaces, that's a must, especially when you treat a risk patient. Then you have to disinfect all the surfaces you touch. Then you have to disinfect all the surfaces 1 to 2 meters around the patient's head. Well, we offer also chemicals, disinfectants. Durantal is a big supplier for disinfectants. We call it system hygiene, and the best methods are some wipes. You can use so-called limited virucidal products to deactivate the coronavirus, because the coronavirus is very soft. It's not a problem for a disinfectant. The fast reaction time comes from the alcohol that is inside, so that's an offer. But we should also at the end discuss some methods to decontaminate the air. I know that there are always questions, what about ultraviolet light? What about the air purification systems? What about foggers, etc.? Let me give you some statements. I don't like these extra oral suction systems because from the ergonomic point of view, because of hygienic point of view, you cannot disinfect them. And I don't think so that there are solutions. So intraoral suction system is a principle of non-contamination. That's the right way. And then we can discuss about some additional things. I know from many countries they discuss about vacuum systems producing a lower pressure inside a room. I think that's not necessary. We can talk about air purification systems, okay? But I think they are more helpful and more helpful in public areas like waiting rooms, like cinemas, like theaters, etc. There the risk is much higher than the risk in dentistry. Ultraviolet, UVC, yes, it could help. There are some studies that they could decontaminate the aerosols. That's maybe something as we are part of the industry. We have to check out if this helps. I don't like these foggers because these foggers, let's say, they contaminate your dental clinic with disinfectants, and disinfectants kill. Yeah. And when you enter the room before the reaction time is gone, then it will kill the cells in your lung. Yeah. So therefore, I do not like spreading disinfectants around and breathing that in. So, but this is my personal opinion. But always people are asking, what do you think about these foggers? So I don't like that. Okay, let me go to a final slide. Okay, these are the references, all the studies at the end. And this brings me at the end to say thank you, but I want to start the discussion. There are still 2 minutes to answer or to check out the questions. And there is a colleague, Luigi, at the back who summarize maybe your questions. And during you ask me the questions, I would want to share another question. How helpful was this webinar for you? And then we can start now with an open-end discussion. Thanks a lot. And Luigi, are there any questions?
Hi, Dr. Koch. Most of them I've answered because it's the same ones that always pop up. There is an interesting one regarding UV lighting in DER suction units, why we do not include UV lighting at the bacterial filter site. I think that relates to the ecto-oral suction because they have UV lighting.
Yeah, that's an interesting question. I do never prove the UV lighting efficiency in these extra-oral suction systems. But I know from studies that you need to be efficient, you need a very high dose of UV light and you need time to be effective. And the flow rates are, as I told you, 300 liters per minute. So the time that the air particles or the viral particles are inside a suction machine, these are milliseconds. And I think the dose is not high enough to really decontaminate that. So that would be my statements from as a microbiologist. Yeah? You need more time to be efficient. When you, we use 30 years ago these UVC lights to decontaminate our surfaces in our lab. But overnight, we switch on the UVC light overnight. So it needs minutes and hours. It depends on the efficiency of the UVC light. Yeah, but I don't think that this is possible in milliseconds.
Thank you. I see the questions are pouring in. So the next one is, how efficient is HEPA filters?
Yep, that's also a very interesting filter question, because a HEPA filter, you know the HEPA, when you go to Wikipedia or Google it, then you see that the HEPA itself, it's just a standard, a test standard. And it depends on the number that follows. Is it HEPA 11, HEPA 13, etc.? Because the number following by HEPA defines the efficiency. Yeah. So once again, a HEPA filter is not like a sieve that filters out everything 100%. It's like a labyrinth. It gives you an efficiency of 99 dot something, depending on the HEPA quality. So it will reduce the risk, yes, depending on the HEPA filtering efficiency.
Then we have regarding the high volume suction, how close are we supposed to place it next to the area of treatment for maximum results?
Just your micro was shortly off. Could you repeat it?
How close, the high volume suction, how close are we supposed to place it next to the area of treatment for maximum result?
Okay. So the efficiency of a suction system depends on the length and the construction of the pipes. Each pipe gives you a resistance. And for example, if you place 100-meter suction line in between the suction machine and your cannula, the resistance is very high. But the resistance is also very high when you place a short distance and a small suction cannula and some angles in between, 90-degree angles. So, and the sum of all resistances will reduce your flow rate. So, and therefore, that's part of our training. We train a lot of planning, the partners, a lot of dealers to plan suction systems in the right way. And there is a planning brochure available for our dealers, for our partners, how to plan a suction light in the right way. And that's difficult, of course, if you use one suction machine and 20 dental units in one line. And therefore, for this, for example, there are also mathematically calculations to optimize this suction line. And that's the knowledge. That's the knowledge. That's the knowledge of a trained partner.
I think there's one question that has popped up a few times. The slide for the Bennett research in the UK dental clinic of the contamination in the air. If you can maybe just snapshot that again briefly on the blue line, the red line, and that there are natural. Thank you.
Okay, let me go back. The problem is that especially this study was not, or I think it's not public yet, so you have to pay for that. Where it was, here it is. Okay, I didn't explain the red line and the blue line. The red line is the total amount of bacteria, so the total bacteria load in 2-meter distance, and the blue line are only Streptococcus. And this is the proof that this bacteria came out of a patient's mouth, because we know that the ratio of Streptococcus is approximately 50%. So when you check our saliva, 50% of all the bacterial load are Streptococcus. So 50%. And the blue line follows in this graph the red line by 50%. And this is the proof that, well, with a very high proof that these bacteria came out of a patient mouth. Yeah.
Sorry, can you just put that slide up? It's not showing. You still have the poll on. Can I close the poll?
Sorry.
Thanks.
So sorry for that. Here we are. Okay, once again. Yeah, here you see a red line and a blue line. The blue line is the total amount, and the blue line are only Streptococcus. And we know that in saliva, Streptococcus is 50%, and the blue line follows the red line. So these bacteria came out of the patient's mouth, and maybe not from the window, from outside. Yeah? So from the patient's mouth, always 50%. That was the proof. Okay, some more questions.
Yes, you mentioned earlier that there is a study that says that takes 30 minutes.
Yeah.
Based on this, would you say that it is advised to wait 30 minutes before disinfecting an area, or recommendation would be to disinfect and then wait 30 minutes?
This is a good question. I never thought about that, but yeah, if you contaminate within these 30 minutes, the surface is once again, from this point of view, it should be better to disinfect before. And the best way should be to disinfect before and after, when you are 100% safe. Yeah, that's a good question. I never think about that. Yeah.
I've had this on my side, and something that I, as a personal recommendation, that is wait for everything to settle and then do your protocol, because then your aerosols and more water particles would have settled on surfaces.
Yeah, of course.
Another one more questions, Luigi? Yes. Can high volume suction cause tissue injury?
No. That's also published in this study there in the 70s. I showed you there. This one, criteria of airflow, because that was one of his questions. What about tissue injuring with 300 liters per minute? And that's not possible up to 400. And from 400 onwards, then it comes to a critical area. So with 300, 350, it's not the problem. And that's another result of his study from the 70s. There was a question, how can I see the recording of this webinar? You will receive in 1 hour a thank you with your e-certificate, and you will receive maybe tomorrow another email with a link to our record, because maybe I will just cancel the questions and I have to edit a little bit. Yeah, so therefore it needs some minutes time. So maybe the next days you will receive another email with the record.
Then we just have one more that
about I saw that should we disinfect after the settlement of the aerosol? I think that was already answered yes. Yeah, from this consequence, let the aerosol settle down and then disinfect. Okay, I think we are at the end. Thank you very much for your interesting questions. Thank you very much for your time. It's 10 minutes after 3 in Germany. Thank you very much and keep safe. And if you have any questions, don't hesitate to ask us, to ask my colleagues from Derdental. We will give you some helpful hints and tips. And we keep in touch and stay safe. Goodbye.